Hello, Peter. Peter, Peter, can you hear me? Peter, I'm on call and I have some consults I have to go see. So Prof. Harris just asked me to start the meeting. Will you continue?
Hello, good morning / good afternoon.
Hello, Prof. Good afternoon.
Hey guys. How you doing?
Uh, I'm better now.
Oh, okay. Were you sick?
This morning I woke up with some headache.
Oh, I think you have two devices on. It's pretty echoing, or I hear a lot of echo. Not sure if that's. I see you're on twice, looks like. Well, I hope you're feeling better.
I initially connected with my computer, so it's giving some feedback.
Yeah, I'm getting a little bit of.
Yes, I hope it's better now.
I think so.
I can't share anything on my side. I'm just trying to figure out what's going on
Okay, let me
on
see if
this
I
side,
can.
but you can continue.
Oh, yeah, it
Peter,
says
if you can.
I can't share my screen. If you guys can give me the permission to share. Yeah, it still says I can't share.
Let me see. Peter, there's something I'm supposed to change on the settings.
See if there's something. Yeah.
Yes, Suraj, the share, if you click on the share screen, there are
Yes.
two options, the host and then the multiple participants. So you
Yeah,
can
yes.
multiple,
I'll
yes.
click on multiple now. I'll click on multiple.
Oh, there we go. Okay, great. Give me 1 second here. Okay. Okay, can you guys see the screen?
Yes, Prof.
Yes.
Okay. All right. Well, let's get started. I have to try to run by about 20 after because I have to go. I have a cochlear implant to put in this morning, so I have to go in a little while. But let's talk about a case, how you'd work it up a little bit. So is it just Peter and Siraj? Is that who's on the call? I can't see you guys, so I don't know.
Yes, Prof. But I'm on call, so I've actually got some consults I have to go see.
Oh, no problem. Okay. Okay. Well, I just want to hear. Okay. All right. Well, let's talk through this. Okay. So say you get a 44-year-old that comes to your clinic and they have chronic imbalance. Let's talk through a little bit about what what kind of questions you want to ask. Let's just talk through that a little bit. So, Siraj, what do you think? If you, in case you have to go, any questions you might want to ask?
I want to ask about the duration. How long has it been? Is there any? And then, so first of all, I want to know the length of time. What's the frequency of the dizziness? Are they episodic? And is it persistent? How many, is it for a few seconds? Is it for minutes? Is it for hours? So I'll ask about that. So duration. And then the next thing I ask about is associated symptoms. Does it have any headaches associated with it? To describe the headaches. Do they feel them on a specific part of the head? With the headaches and with that, is there also associated nausea and any episodes of vomiting? And want to talk about that, the nausea, vomiting. And then also it's orthological, I want to ask about, is there hearing loss? Is there hearing loss? If there is hearing loss, to describe the hearing loss, to tell me if it is persistent or if it is fluctuating hearing loss. And then with the hearing loss, I also want to ask about, is there tinnitus? Do they have tinnitus when they get these episodes? To describe the tinnitus to me as well, and to tell me if it is persistent or if it is fluctuating. And basically, I want to sort of go around: is this a Meniere's? Is it going to be hearing loss, tinnitus, and dizziness? Just to put into differentials to help me with my differentials. The next thing I want to ask is, are there any other neurological symptoms? Do they have difficulty with talking? Do they have difficulty swallowing food? So dysphonia, dysphagia, yeah, so those are the main sort of things I would start with asking this patient. Yeah.
Yeah, that's good. That's really great. Good morning, Brad. Yeah, that's really great. Yeah, no, you've touched on a lot of things. Obviously, the key that I found in clinic is patients will use the word dizzy a lot. And so I think it's really important at the very beginning to have them use words other than dizzy, right? Because dizzy is really not a very helpful word. Dizzy could portend lightheadedness. It could be listing, like they're just kind of, moving to one side as they walk, feeling like they're on a boat or rocking, certainly lightheadedness, and so all of those could fall under the patient descriptive of dizziness, but they could mean completely different things. And so it's really important to, right from the get-go, is have them use the word other than dizzy to describe exactly how they're feeling, right? So you touched on a lot of good things about timing, any precipitating events, any things that make it always, kind of, it's almost like with pain, right? What makes it better? What makes it worse? Is there anything that reliably incites it, or was there an event? And of course, asking about otologic history, which you did. Is there concurrent hearing loss? So you mentioned Meniere's disease. Do you guys know what is the what's the clinical criteria for somebody with Meniere's disease? Do you guys know? And I'll open up to either one of you, Peter, if you want to chime in on that too.
Yes, Prof. So for many years, we know the symptom of vertigo or a spinning sensation can last from minutes to hours, and for some people can even go up to a day. Tends to be fluctuating, and it's also associated with a fluctuating hearing loss, tinnitus, and oral fullness.
Right. Yeah, exactly. So you have to have, it's a clinical diagnosis, right? We don't really have a bona fide blood test or an imaging study or anything else to suggest. So people can do electrocochleography, and they've suggested that if elevated, can be consistent with Meniere's disease, but you're absolutely right. So the clinical diagnosis is the most important. So the symptoms, so this patient does not have that. They're describing more chronic imbalance. And so they state that she's feeling fatigued quite a bit, even though she sleeps. Describes the dizziness as being triggered by a cell phone. So almost like feels that the room will tilt. And then episodes usually last for a few minutes before she regains kind of normal functioning sometimes. And then she also feels like she hears her pulse in the air. So you asked some good questions initially about tinnitus, right? So tinnitus, you always want to ask, tinnitus is phantom sound in the absence of a sound stimulus, right? And so it's important to look at subjective versus objective, right? So some people can actually hear the heartbeat or pulsatility. Sometimes you can actually hear it if you auscultate with, a stethoscope around the ear or the neck. So really important if you ask about that as to what kind is it? Is there pulsatility? Is it not pulsatile? If it is pulsatile, what mitigates that? Is it, can they change it? Exactly. Okay. So thoughts on this? Is there anything that when you look at this, are you starting to think about anything in particular? Or are there any other questions that you guys might want to ask?
Well, so about the pulsatile tinnitus, well, the commonest will be to just ensure that it is really pulsatile, it is synchronous with her heartbeat and all that. And we know for the ear, we will be thinking about something like a glomus tumor, which can cause a pulsatile tinnitus. But in any case, we should have checked the blood pressure to be sure she's not having palpitations, which she's feeling in the ears. So for somebody who is hypertensive, it will be good to just cross-check that the blood pressure is okay. So
I tell you that her blood pressure is normal. And she doesn't describe. So if you're thinking about possible glomus tumors, things like this, what else can they present with? Is there any other kind of outward symptoms that they might describe that would make you concerned about that? Other than pulsatility.
So we will need to cross-check the general state of a patient, if there are any other illnesses, if the person has sweaty, the person has hot flashes, the person has any changes in the eye, like I'm just thinking of somebody who has a hyperthyroid state. It could also it could also come up like that. Have there been any changes in the any new medications that the patient has been put on now?
You mentioned something about sweaty. Why would you say sweaty and glomus tumors? Why would you say that? What's the connection there?
For patients who have pheochromocytoma, they can have that kind of presentation. So it's good to find out.
Right. And why is that? What's the underlying cause for that? So you say that they could have another satellite lesion somewhere else, right? So, but what's ultimately happening? Why might they have high blood pressure or feel sweaty or palpitations or nervousness or these things? Why is that happening?
I know in if you have a glomus tumor which is affecting the adrenals, then you have aberrant secretion of
Can these tumors secrete agents that might create those symptoms?
Yes, that I can't remember exactly.
Okay. Yeah. Have you heard of metnephrines, normetnephrines? Have you heard of those before?
Yes.
Right,
Yes.
right. Yeah, exactly. Right. Yeah. So obviously some of the pulsatile, you're absolutely right. You want to ask about those symptoms. She doesn't have any of those. She just feels some fatigue, but doesn't have any of those other symptoms that you're describing. So your physical exam, so the next thing is so now what are you guys looking for on physical exam? So Siraj, let's go back to you. So she's otherwise healthy. She's got mostly left ear symptoms. It's pulsatile in one ear. She has some chronic imbalance that might be precipitated with certain circumstances, maybe like during her day, like certain sounds. But just kind of feels chronically imbalanced. She's not having vertigo attacks per se. She's never had any other, ear symptoms. No, you always want to ask about ear surgery, right? I always ask any previous ear surgery, any infections. And the way I ask that is most patients will describe infections related to pain. So I always ask, I say, have you ever had chronic ear infections? What I mean by that is, have you ever had blood or pus coming out of your ear canal? I'll try to, because a lot of people will equate ear pain with an infection.
Sorry, Prof, my apologies. I've got
Yeah. Oh, do you have to go?
Hold on, I have to answer my phone. Sorry.
Oh. Sorry, you have to go, Siraj?
Yeah. I've got
Oh, I'm sorry. Okay. Peter's on square on the hot seat then.
Yes.
Thanks, Siraj. No problem. Thanks. So Peter, no ear surgery, no chronic infections, no pain, no real discrete vertigo attacks, maybe occasionally under some discrete circumstances, maybe some noises might do it. But otherwise that's what she has. Okay.
Yes, bro.
Okay. So, what do you want to look for on her exam? Anything in particular on a physical exam?
Okay. So, for the ear, because I'm thinking of a glomus tumor, I want to see how the same examination as we do for everybody, but with emphasis on whether we see any changes in the tympanic membrane, or whether we see, like we discussed some time ago, we see some kind of a reddish mass which is in the middle ear, for which we will have to do a pneumatic otoscopy to see whether the tympanic membrane will be adherent or will move off that that reddish swelling. But aside that, because we are thinking of other possibilities, we'll need to examine the neck, for instance, for neck masses. If you have a carotid body tumor, it could also present like that. So we need to look for a neck masses. We'll need to yes, the blood pressure, like we mentioned earlier, we'll have to be interested in that before. And then also look for the ear. I'll still be interested in any hearing loss, maybe even if it's not something that is obvious to the patient. As we do the tuning fork testing, we'll see whether there's anything to point to a hearing loss.
Okay. Okay. So you want to get a hearing test. We're going to get an audiogram. So if I tell you that her exam is normal, okay.
Yeah. Okay.
Yeah. So you don't see anything behind the ear on binocular microscopy. There's no masses, lesions, tumors. You always want to ask about cranial nerves, right? You want to check all the cranial nerves, right?
Yes,
So
yes, please.
you always want to comment about lower cranial nerves as well, right? So you want to look at tongue deviation. Is there is there unilateral like atrophy, hemiatrophy of the tongue? Does it project one way or another on protrusion? You know, how's the palate? How's the voice quality? Scoping, endoscopic exams, these types of things. Quick question before we look at the audio though is you're mentioning a lot about glomus tumors. Do those typically cause chronic disequilibrium in your experience? Have you seen that they cause chronic imbalance, or do they cause just maybe more ear symptoms? What do you think? Like pulsations?
Well, I haven't seen too many, but the few I've seen, they are more of the ear problems than a chronic imbalance.
Yeah. So it may not, your thoughts about a glomus tumor may not address the imbalance, right? So you have
Yes.
to be thinking about maybe something else as well, right? Or something else. Okay. Okay. All right. So can you go through can you tell me about this audiogram?
Okay. So for the right ear, the hearing thresholds are normal. For the left ear, we have a mild rising to normal conductive hearing loss on the left ear.
Yeah, right. So you see a little conduction problem there, correct? It turned 5,500 hertz. Yeah, now I'm not giving you some information you may need, but so now you look in her ear and you see nothing. The ear looks completely normal on the left side. So you're looking at this and you're, what other information do you think you need here? What does this make you think about?
Well, if we can get the tympanometry, the stapedial reflex done to see whether there's anything to pick from there before going on to do a scan.
Okay, so what if I tell you that the tympanometry is normal? Okay, type A timps bilaterally.
Okay.
And you have present acoustic reflexes in all conditions.
Okay.
So what do you want to do next, or what do you think?
Well, then
based on this, can you give me some other thoughts about what else might be going on with this lady and what you might need to do?
is it possible that we have a superior semicircular canal dehiscence, for instance?
That's possible. Yeah, that's one possibility. Why do you think that?
So since we have a positive stapedial reflex and we have a conductive hearing loss. Most of the time, the confusion is whether it's between otosclerosis or superior semicircular dehiscence. In this case, because the reflex is positive, I'll think more of a superior or lateral semicircular canal dehiscence.
Okay. Okay. Yeah. No, that's good. Okay. Anything else? So you're thinking SSCD, otosclerosis. What other possibilities could it be?
Because it's a conductive hearing loss, it's limiting how much of, because if it's anything in the inner ear, then we should rather be having like an acoustic neuroma or something like that. We should be having a sensorineural hearing loss rather than a conductive loss. So it makes me wonder what else could cause a conductive hearing loss with a positive stapedial reflex.
Okay.
That's my challenge now.
Okay. So what about her symptoms of imbalance though? How's that explained? Can you think about that? So in light of the audio, what she's describing, so you're thinking maybe SSCD, what kinds of symptoms does someone with SSCD present with? Can you give me like 3 or 4 hallmark sort of symptoms that those folks present with?
Well, so there's tinnitus, there's
What kind of tinnitus? Can you be more specific about the tinnitus?
I think that one is episodic.
Episodic, no, what I mean is it a subjective one where they hear like a buzzing or a ringing, or is it pulsatile, or is it both, or can you tell?
Well, this won't classically be the pulsatile type though, but not very. Wow. Well, it's possible for them to have a pulsatile tinnitus and the hearing loss.
Right. So hearing loss, which can give you, right, so they can have, so people with SSCD definitely can have pulsatile tinnitus, right? They can present with that. So one thing to think about is if someone comes in with pulsatile tinnitus, you don't want to immediately think glomus tumor, right? That certainly is in your differential, but you got to be thinking, is there a skull-based dehiscence? Is there a vascular anomaly? Is there a dehiscence of the skull-based vessels? Could it be benign intracranial hypertension? So, these are things you don't want to immediately go right to glomus tumor. Certainly it's in your differential, but you got to be thinking about these other things. So people with SSCD certainly can present with this, right?
Okay.
So pulsatile tinnitus is one of the hallmarks, okay?
Yeah.
Chronic imbalance is certainly one as well, right? So folks will come in and they'll just say, I'm chronically imbalanced, but they may have episodic attacks. What was it about her history that was interesting that could tip you off? I mentioned that she was feeling chronically imbalanced, but she might have little attacks if something happened.
Sound okay. The Tullio phenomenon.
Tullio phenomenon, right?
Okay.
Yeah. So little keys in the history are really critical, right? So when you ask about, are there any precipitating factors that you experience that exacerbate your symptoms? So in this situation, she said, oh, sometimes the phone. So maybe she has the phone next to her ear or talking and it sets off, makes her feel, so that's called a Tullio phenomenon, right?
Yeah.
So what if there's a column of pressure in the ear, like maybe, what is that called? That can incite vertigo.
Is it the endolymphatic hydrops?
No, there's a different phenomenon. There's a Tullio phenomenon, and then there's a different.
Hannibert.
Hannibert's, right? Hannibert phenomenon. Some people describe pressure columns in the ear that can incite vertigo, right? So you always want to ask those questions in your battery. Somebody who comes in with chronic imbalance and pulsatile tinnitus, or just even chronic imbalance, should be part of your part of your, your, history is to ask them about
Mm.
those types of things, right? So yeah,
Yes.
so she checks a lot of these boxes, right? So she's got pulsatile tinnitus, she's got chronic disequilibrium. If you ask her a little bit further, she'll say, "Yeah, my ear feels full all the time. I have this
Mm.
chronic fullness in my ear." Which is another tip off. Now, people with Meniere's disease can have fullness in the ear, but it's episodic, right? And it comes with
Yeah.
vertigo, right?
Okay.
That's unprovoked, right? It doesn't have
Mm.
to have something in the environment stimulate them to evoke the symptoms, right? Unlike something like
Yeah.
SSCD, for example, right?
Mm.
So all really good pointed questions to ask. So if we looked at it, right? So SSCD is high on your list, right? Migraine certainly can give you a whole cadre of symptoms, but usually it's not going to give you what on the audiogram. You're not going to usually see a
A conductive hearing loss, for
right, a
instance.
low frequency conductive loss, or what we call a supernormal bone line, because they call this a third window phenomenon, right? So you're shunting
Mm.
fluid away from the inner ear, resulting in some of these effects you see on audio.
Mm.
I don't know if
Yes,
you've done
please.
any reading, but something that's becoming more prevalent that people are describing is called 3PD, or postural perceptual dizziness.
Mm.
Uh, that's something you may want to read up on. We could talk about that another
Yes,
time.
please.
But that's an interesting new phenomenon that people describe that can be ameliorated or treated with like SSRIs, or serotonin specific reuptake inhibitors.
Mm. Yes.
On your physical exam, you always want to do a good neurologic exam, right? Because what if someone with chronic imbalance could have an uncompensated peripheral vestibulopathy, right?
Yes.
What if she had suffered something and doesn't look like it from the audio, but you always want to do a good head thrust test, maybe a head shake. You want to be looking for corrective saccades, right?
Mm. Yes.
Of course, skull base or retrocochlear pathology, we're not as concerned about that usually with a low frequency loss, but you never know. Something could be eroding into this is causing this, right? So you don't know, right? So you don't know, is there something that's occult? And then, of course, the skull base vascular abnormality, right? Which is kind of
Yes.
what we talked about earlier. Okay. So you want to be thinking about your differential, obviously, but you always got to ask really pointed questions that help guide you. Okay.
Okay.
So, all right. So what's next? So you've got this patient, you've got the audio, this is your sort of your differential. Brad, feel free to chime in if there's anything else that we need to think about in terms of a differential there.
So I think you're doing a good job. Continue.
And you also mentioned otosclerosis, right?
Yes.
Does otosclerosis necessarily present with disequilibrium?
Well, not really. The hallmark will be the hearing loss.
Mm-hmm.
Some will have tinnitus, or hearing loss, tinnitus, but not more of imbalance. No.
Mm-hmm. And you hit it on the head, right? Because in the audio, you asked the right question. You asked about the acoustic reflexes. What if the reflexes were absent in that ear when I stimulated that ear and recorded from that ear? Or even, even if they were just absent with the stimulation on the left, even if on the right it was still absent, maybe what might that tell you?
Well, then autosclerosis becomes high on the differential list.
Yeah. That's right, because on the pure tone averages, when they do the bone and air conduction, that can look like otosclerosis. You don't have to have that classic Carhart notch, kind of that 2 hertz, the 2K notch loss that we often see with otosclerosis, right?
Yes.
Yeah, right.
Last week we had a patient who had what we thought was autosclerosis, but we had seen some tympanosclerosis on the microotoscopy, and Prof decided to just examine to be sure, and just to examine the middle ear, and really it was the autosclerosis, tympanosclerosis, that was fixing all the ossicles.
Yeah.
So,
Yeah. Typical sclerosis can be quite aggressive and extensive. And it's challenging to fix that. It can really infiltrate into the middle ear and infiltrate around the ossicles. And I've seen several cases that really challenging. Absolutely. Exactly. Okay. All right. So what do you want to do next for this gal? What's your next step?
We'll do an imaging and we'll go for a CT scan of the
Okay.
temporal bones.
Okay. So I'm giving you a coronal view here. It's just one limited cut here, but describe what you're looking at.
Yes, so I think for the left side, we see the external canal, we see the tympanic membrane with the handle of a malleus attached. The cochlea is all covered with bone, but you can see that the superior semicircular canal opens up into the brain. It's not covered with bone at the superior limit.
Yeah, and what else do you see? What else what else is kind of an important finding on that scan?
Okay, well, the more in, I would say, the hypotympanum, where you see a soft tissue density there. As to whether it is significant or not, I can't really tell.
Right.
And
That's
then
true. That's true.
and then the tegment tympani, I don't know whether it's a cut at this level, but we don't see any bone. The roof of the middle ear is all absent.
Right, right. So that looks like she may have a dehiscent tegment tympani, right? With maybe an early encephalocele, possibly, right?
Okay.
Yeah, that's important, right? That's going to be really important for your management decisions, right?
Yeah.
Okay. Okay. So now what? How do you counsel her? What do you say you're going to do? So now pretty well made the diagnosis here. It doesn't look like she's got a big scar. Now, just, again, you're looking at one cut here, but let's say you've looked at everything thoroughly. You've seen all the cuts, axial, coronal. Now what are you going to do? How do you want to counsel her? What, she comes to you, she's got this problem and you've pretty well diagnosed it. Let's just say in the axial view, another important thing to note here is you always want to look at all three balance canals, right? Sometimes people can have dehiscences of the posterior canal that people sometimes miss, and that can lead to some issues. So you can still have a third window phenomenon with a posterior canal dehiscence. So it's really important to look at all of these balance canals. So make sure you look at your axial views as well. Okay.
Yeah.
So what do you want to do for her? Do you tell her there's nothing you can do? Do you say medical management? Do you say just live with it? What do you say?
So the option of medical management is there, but so where people have given things like amitriptyline and other medications to just contain headaches or any associated symptoms, but definitively the best would be to close off the dehiscence or in the semicircular canal. In this case, well, I don't know whether the thinking of encephalocele is something to worry about, but that would depend on what we found when we look at all the cuts.
Okay.
So various surgical options are possible.
So if she asked you said, okay, oh, go ahead.
Yeah,
sorry.
So various approaches are possible.
Okay.
transmastoid.
Okay.
Then we also discussed the skull base, where the approach where you open up the skull base and plug the histons, not through the mastoid.
What is that?
I know there's translabyrinthine, transmastoid, and the one through the skull base is the term I've forgotten the correct description.
Okay, so you can either go transmastoid, or what do you call it if you're going above the ear? The brain sits in 3 fossas. What are they called?
So that's posterior fossa approach, is it?
What lives in the posterior fossa? What part of the brain?
The
Well, there's 3 fossas. What do you remember the names of them?
yes, the
The
anterior
frontal lobes live in which fossa?
the anterior fossa, the middle
Okay.
cranial fossa, and the
Ah,
posterior cranial fossa.
okay, good. So is this would this be an anterior cranial fossa approach?
No,
What part of the brain is living right above the ear?
the middle cranial fossa.
Yeah, middle cranial fossa. There you go. Right. Temporal lobes, right? Temporal lobes of the brain, right? So frontal lobes in the anterior fossa, temporal lobes in the middle fossa, cerebellum in the posterior fossa, right?
Yes.
So yeah, so you have a transmastoid approach or you have a middle fossa approach. Right,
Okay.
exactly. So any ideas on what might, basically looking at this scan, can you tell her, she says, well, what do you think, doc? Which way should you, if you're going to repair this, can you give indications about access on both approaches? Is there anything that tells you about which, if you're going to perform surgery, which approach based on this would be more ideal and why? If you don't know, that's okay, but I'm trying to get your thought process about just looking at her anatomy and thinking about, based on approaches, what would be more indicated or more ideal. And you could tell a lot from this CT.
Well, that's a bit difficult for me to tell, but
I'm gonna fast forward for one thing real quick. We may not get it through this today, but right here, if I showed you this film right here, or this picture right here, okay?
Yeah.
Tell me what you're looking at right here.
So that's a cortical mastoidectomy. We see the
Which ear is it and why?
okay. This is the right ear.
Okay, and why do you say that?
We see the tegmen, which is on the left side of the image. The lateral semicircular canal anteriorly will be the incus. Yeah, so
what's the SS and the DR? What does that stand for?
okay, the sigmoid sinus and the digastric ridge.
Okay. So pretend you're looking at this one. I know it's a right ear and we're looking at the left side, but think about her anatomy that you just saw in the CAT scan. Where does the superior semicircular canal live? Can you talk me through where, if you were drilling on this bone, where do you have to go to find the superior semicircular canal?
So
where does it live here?
Okay. Between where the tegmen and the lateral semicircular canal, that region is where we'll find the superior semicircular.
Right. So it's deeper there, right? You don't see it on this cut, right? There's a lot of bone there between the middle fossa and the lateral canal, correct?
Yeah.
Yes, you have to go a lot deeper there. So now think about her film. What was interesting about her film that might dictate the challenges of an approach? So keep this in mind, and let's go back here. What do you think about that coronal? Talk me through what you see there, and then what we just looked at with a transmastoid approach. Can you talk me through this? I know we're kind of going through this in minutia, but it's really important, right? Because it really is this is really important part of this, because think about how, if you were going to do a transmastoid approach to that superior semicircular canal in this patient, do you think that'd be a real straightforward? You'd be able to find the superior canal dome, or even part of it really easily, or is there a problem with that? Or is there a challenge with that?
I'm just wondering whether the thickness of the density of a mastoid will pose a challenge as you approach the superior semicircular canal in this case.
Probably not the bone. What's the gray stuff that's coming down right over that's draping over the superior canal and almost into the middle ear? What's all that?
Okay. We said the tegmen was dehiscent, so we have brain tissue.
Yeah. So if you think that she's really dehiscent there and you don't have a transmastoid look on this yet, you don't have how do you think that looks here? As you're drilling, do you think think about now as you're drilling toward that superior canal, do you think that that's going to be an easy approach there? Or do you think you could be running into dehiscent brain?
Okay, I agree that then we will have dehiscent brain tissue to deal with.
Right. So that's a challenge, right? So one of the things you have to think about here is, and you're absolutely right, a transmastoid approach, you can approach the superior canal from below. But in a situation where you might have again, you have to look at the axial views and you have to look at those cuts further back over the tegmen mastoideum. That will really dictate a lot about your approach here. Okay. So if you are drilling here, you may have, if she's got a big dehiscence over the tegmen mastoideum that extends over anteriorly into the tegmen tympani, you might have frank dura and brain sort of just, falling down. And that makes it really hard to drill around that, right?
Yeah.
You're putting the brain at risk. You could damage the dura. You can do all kinds of different things there that could cause problems, right? So now the other issue too is, and again, you're probably not going to do a lot of this in your practice, but it's just important from an anatomical consideration. You mentioned she does have a tegmen tympani defect there, right? So we do know that, right? So we're at the level of the tegmen tympani there because you're right over the middle ear space. Is that repairable from below? Can you easily repair that defect from a transmastoid approach?
I guess if it was just a small dehiscence, you could repair it, but this looks like all through you don't have any bone at all on the level of the tegmen tympani, so it might be more challenging trying to repair such a defect.
Right, exactly right. So she's at risk over her time. She's only 44. She's at risk in her lifetime of maybe developing an encephalocele, maybe even a CSF leak, right? She may present to an emergency department with ear fullness and maybe fevers and maybe meningitis symptoms, maybe. No guarantee on that. I'm not saying that's going to happen, but based on how this looks is, she could have that could happen, correct?
Yes, please.
Right. So this when you see this kind of situation here, she's got, no bone over the tegmen tympani. The approach from the transmastoid would really be tough. And we can talk more. We'll have to talk next time about this. But so really everything here dictates, is kind of indicating that a middle fossa approach would be better. So because you can actually you can address two problems at the same time. You can, number one, you can plug the superior canal dehiscence. And number two, you can repair the skull floor with a calvarial bone graft. So you can address those two things in the same setting. Now, I have to go pretty soon because I have to get to the OR, unfortunately. Sorry, guys. But let's talk for a minute about two other things. And then we'll talk more next week about the details of this approach. But number one is, does all SSCD need to be repaired? Is that a life-threatening thing? Is that something that every time you see it, say, oh, we got to fix that? What do you think?
Well, Prof, because there's the medical management and surgical management, depends on how bad the symptoms are for the patient. If this is not causing any significant imbalance, or the person just has a tinnitus which is not really bothersome, I think we can do away with medical management. So I think it all depends on case by case basis on the patient we have at hand. If the patient is very uncomfortable, then it must be that surgical options become the necessary.
Right. So there really isn't a medical management for this problem, right? So the real issue is exactly right, is if you can attribute the patient's symptoms to this problem, it really, we call this a shared decision, right? So it really comes down to the patient's lack of tolerance for those attributable symptoms to SSCD that really dictates whether or not you're going to repair it. So if they say, I can't deal with this pulsation anymore, I cannot deal with this fullness in the ear or this chronic imbalance, and those things can be improved by plugging the canal. So, but you have to be very sure, because the challenges with SSCD is sometimes there's an overlay of migraine. I mean, I see a lot of it, particularly in more middle-aged women. They may be perimenopausal, they might have migraine. It's really important to make sure that you can try to tease out those two things, because sometimes you don't want to be doing this surgery on this patient and all of a sudden you haven't improved their symptoms. So number one is really be thoughtful about the symptoms, and number two, before you perform surgery, you really have to know that it's the symptoms that they're complaining about that are so life altering are related to this before you go forward with that. Okay, and then you also have to address the other ear, because what happens is many times they may have bilateral canal dehiscence, but they're more symptomatic in one ear. And I always give them the crying babies analogy. What is that? Well, if they have two, say if you've got two crying babies in the room, and one is crying louder than the other one, okay?
Yeah.
What happens when you silence the louder crying baby? I.e., if you plug the more inciting ear, what's left? Well, the other one was crying all along. You just couldn't really hear it because the other one was so loud. So there can be an unmasking of the other ear now, where they can still have symptoms, but you just didn't, it was kind of overshadowed by the other side that was much more involved. Does that make sense?
Okay. Yes.
So you have to be thoughtful about what's going on in the other ear as well, and counsel them about that and say, well, if we fix this one ear, this other ear looks like it's probably dehiscent as well, but you don't seem like you're as affected. So this could unmask this, and you might have symptoms now that are more noticeable in the other ear. So there's a lot of nuance there. The last thing we'll say is that, I always work these folks up for benign intracranial hypertension. The other issue is having an eye exam, look for papillodemas. Do they have benign intracranial hypertension? Do they have sleep apneas? Remember, she said she was tired a lot. Maybe she's got undiagnosed sleep apnea. You got to look about things like obesity that can increase congestion in the head and neck. And so those are other things that you may need to look at because puts you at risk for the other ear, or it can eventually wear your repair down in the surgical ear. You want to try to manage those things as well. Okay.
Yes.
Brad, if you want to stay on and chat, I unfortunately I have to get to the OR this morning, guys. Sorry, but I think what we'll do, Peter, was this helpful so far on this kind of workup?
Oh,
for this?
yes, Prof. It's helpful. Sometimes when
Yeah.
you
So
just read, you how to apply the information is
yeah,
different. So
you'll probably see a lot of this. So, and be really important to be thinking, having this in the back of your mind. We'll talk now. So the next week, let's talk through more detail about the surgical approaches and the anatomy. Okay.
You're
okay,
gonna
yes,
touch
Prof.
on VEMP also a little bit next time.
Yeah.
Good.
Okay, okay.
Yeah. Yeah.
Okay.
So guys, well, I'll see you later. And sorry, guys, I
Yeah.
don't mean to bail on you.
Thank you
Thanks.
very much.
Nice case. Stay
Yeah.
on for 1 second, Peter.
Yeah.
I have a couple of questions
Yes,
for you.
Prof.
Yeah.
Yes,
You guys
Prof.
have a good weekend. Thanks,
you, Greg.
guys. See you soon.
Bye-bye.
Bye.
So one question I have is just in regard to availability of nice high resolution CT scan. Are you and patient's ability to cover that? Is that something that you're able to easily do in Cape Coast, or is that difficult?
Well, so the facility is available, but affordability is always a challenge. It's not covered by national health insurance, so it's people who can afford who get to do it.
Mm.
So for those who can't afford, you're forced to try and work through something for them without scans.
What is the proportion of patients who would be able to afford a high resolution CT scan like that, roughly? I mean, I'm sure that I'm not asking, is it just in general, is it like 50-50 or maybe 20% of patients can afford it, or what would be
20% can afford it readily, but you can have another 20 to 30% who, when given some time, they can work at getting funds to get it done. But just that sometimes that's how long it takes can be too long. So
okay. Do you have an option of just plain film tomography, or is that not any less expensive or available?
X-rays are easily available.
Okay. The other comment I was going to make was just that, and I think Greg's going to cover this more. I agree with him that when you've got a large Tegman dehiscence like that, it's much more likely that going through the middle fossa approach above the ear and coming from above down gives you good access to cover or to plug the canal defect and maybe reconstruct the tegmen a little bit. But if you don't have a large tegmen defect, but you do have a dehiscent superior canal, one of my partners always does those transmastoid. And so even though it's maybe hard to get up on top of the superior canal, you can gently drill away either side of the area where the fenestra is and plug the canals from transmastoid approach, so you don't have to necessarily get on top. I prefer to go above. I find it just easier to come in from above the defect and then plug it from above. But my partner is quite successful at plugging them from a side approach as well. So, yeah. So yeah, I think that's an interesting discussion, and I think that a lot of patients. It seemed to me like from what the picture that he painted, the clinical picture for this patient, was that it sort of gave her the tilt when she used her cell phone, but it didn't seem like she had a lot of symptoms otherwise. But I'd say probably, a third or more patients that have this, once they know what it is, they say, fine, I'll just live with it. They don't want a mini craniotomy to fix it. So at least
Oh,
that's
okay.
my experience.
Okay.
Certainly, um, his crying baby analogy is an interesting one, since we had twins. We had two crying babies a lot, and I never thought of it that way. I think the answer was, if they're both crying, your wife gives you the elbow to go get the other one. I don't notice that she ever
Yes,
ignored
bro.
both of them crying at the same time, but that's just practical experience.
Yes, yes, yes.
All right.
Okay. All right. Thank you very much, bro.
All right. Good to see y'all.
Okay.
I didn't get to see you, but nice to chat. Have a good weekend.
Okay then, bro. Bye.
Thank you. Bye-bye.
Bye bye.